Dr. Steinberg, Stanford University.
So first I wanted to thank BJ and Sherry for organizing the meeting. I guess this is your fifth moyamoya.com gathering, and a huge turnout. And it's really become a large family, thanks to everyone involved. I think it's really terrific the way things have evolved. So, and it's also, Mike Scott and I are on a lot of panels together. We see each other, and I always learn so much from their experience, and it's a pleasure to be collaborating with them on this disease. So I'm going to tell you about the Stanford experience over the last 20 years, and I'm sure most of you know this, we've all gone over with you, but moyamoya disease is a disease where the arteries at the bottom of the brain, this is an angiogram, this is the carotid artery, and the vessels occlude. The carotid artery comes up and then it stops, and we don't really know why, and there's a lack of blood flow to the brain. All of this should be filling with blood. And secondarily, you get these moyamoya collaterals. Moyamoya means haziness, like a puff of cigarette smoke is what it means in Japanese, and that's what these moyamoya vessels are, and they can hemorrhage. So the disease is at the bottom of the brain here. You're looking at the ventral surface, and it's this artery, the carotid, which occludes, and sometimes the middle cerebral or the anterior cerebral or even the posterior cerebral become very narrow, and that's what this shows in an unfortunate patient who didn't make it. And these perforating arteries, what they're called, they're tiny little arteries, less than a millimeter in diameter. They proliferate, they grow and enlarge, and that's an example at autopsy of what happens. And that's an attempt by the brain to provide more blood flow. Most patients actually after treatment do well, fortunately, and so it's rare to have an autopsy, but this was from a patient who was autopsied. This is a normal artery, and it's stained, and you see that this is the lumen, this is the space where the blood flows in here, and this is smooth muscle here, and in the moyamoya arteries, the ones that become occluded, there's thickening of the inner lining and increased growth of the smooth muscle into the lumen or the space, and that causes clotting of the artery. Patients can present, as I say, with hemorrhage from the moyamoya vessels. That's a deep hemorrhage in the brain in a patient, and sometimes the hemorrhages can be very severe. This is one into the water space, the ventricle of the brain, in a patient who became comatose and paralyzed below the neck. Actually made a good recovery over time, but very, very bad hemorrhage. It was first identified in Japan in the 50s, felt to be a disease affecting only Asians, but as I'll show you, as all of you know, it's not just an Asian disease. The prevalence, or the number of patients in Asia, is 6 per 100,000. The incidence, that's the number of new cases per year, is about 0.54 per 100,000 a year in Asia, and this was the estimate in the US, about a tenth of that, but it's probably higher. We all think it's an underdiagnosed disease, and many of you may have had that experience. In Asia, it's been described as a bimodal onset, first, third, and fourth decades, and Suzuki back in 1969 described a staging system where the vessels at the base of the brain, including the carotid, become occluded. Then the moyamoya collaterals start developing. There's further occlusion of the normal native vessels and the increase in the moyamoya vessels. And then the moyamoya vessels start burning out, and there's collaterals from the external carotid artery, from the scalp and the skull, and finally those burn out, and there's very little blood flow. It's not clear that it's always a progression from this stage to this stage, but these are the different stages that have been described. And we looked at many of our angiograms, and Nadia Khan, who many of you from Stanford met, she was with me for 2.5 years as a fellow, she's back in Zurich, found another finding, which is as the vessel, the carotid occludes backwards towards the neck, we see a secondary change in the neck where the vessel becomes narrow. It's called a bottleneck sign. It's only described once, I think, in the literature. We're just writing this up. And that is sometimes confused with atherosclerotic disease or a dissection of the artery in the neck, and that can confuse the diagnosis, actually. But that, we think, is a secondary change to what's going on up in the head. Moya moya can progress on angiograms. This was someone we saw, we treated the other side, the left side. The right side, which was not symptomatic, was only a moderate stenosis here, but it progressed over 7 weeks to a high-grade stenosis. So sometimes moya moya can progress quite rapidly. We looked at patients, and 18% of our patients had unilateral primarily disease, which means on the other side, they had either absolutely no disease or equivocal or very mild disease, and we followed them. And those patients we followed for more than 5 months. 32%, 6 of the 19 developed significant narrowing on the other side over 5 to 60 months. And interestingly, if there was any disease on the other side, even equivocal, 3/4 of them progressed. If there was absolutely no disease, totally normal on the angiogram on the other side, only 1 of 12 had progression. So it is important, though, to follow patients who have unilateral disease. And 4 of the 6 who progressed actually required surgery because they became symptomatic or had problems. Medical treatments don't work, as you all know, and the only effective treatment is surgery, and that is to provide additional blood flow to the brain from an extracranial source of blood flow. And the idea is that improves blood flow, prevents the kind of strokes and TIAs that occur from lack of blood flow, and it reduces the stress on the moya moya vessels and prevents hemorrhage. I'll talk a little bit about that. There are many ways to do this in terms of revascularizing the brain. I prefer the direct bypass. Actually, a direct plus an indirect is what I like to do. And usually the superficial temporal artery in the scalp is the artery that I use. And there are many indirects using laying the artery on the surface. Mike Scott will show you some of this data, his data, which is a superb series. You can use muscle and artery. I'll show you actually using a vascular substance from the abdomen that we've done. Burr holes may work in some patients. Here's our experience over the last 2 decades, 519 patients and 858 revascularization procedures in patients 1 to 69 years old. And you can see how our experience grew over since 1991 when we treated 1 patient. In 2004, I started collecting blood to analyze for DNA, as well as cerebrospinal fluid and arterial samples, and I'll show you some of the data. We're doing about 100 bypasses a year for moya moya. Our patients, although they do come from all over the world, we have 16 countries represented, including, interestingly, a patient from Japan and Korea, and why they had to come to us. It's not clear. There are many competent neurosurgeons in those countries. The vast majority are from the United States, and about 1/3 of those are from California, but we've got many states represented. Just got one. We didn't have anyone from Alaska. We have no one from Massachusetts. I don't know why that is. We had one but it's interesting to meet people from all over the country and world with this disease. In our series, 3/4 of the patients are adults, and about 1/3 are under 18 years old. And you can see the distribution. It's not quite bimodal, but this is a selected referral base. Our patients range from 1-year-old, probably more 30 to 50, and then it tapers off. As I mentioned, while 1/3 of the patients are Asian in our series, it's not just an Asian disease. Half are Caucasian. Every ethnic group is represented in the patients that we've seen. Hispanic, African American, and as with many cerebrovascular diseases, 70%, a majority are female rather than male. As I mentioned, about 90% of the procedures we do are direct, although, as I'll show you, we really do a direct and indirect at the same time. When it occurs as an isolated disorder, we call it Moya-Moya disease. That's most of the patients, but we've seen patients with many other associated disorders. And this is interesting because many of these disorders have a genetic basis, and that makes us think that there's some genetic component to Moya-Moya. We've had patients with Down syndrome, neurofibromatosis, Graves' disease, which is a thyroid disease, and I'll show you some of these different syndromes. This is one syndrome I hadn't seen until a few years ago, and this is primordial dwarfism, MOPD2, which is associated with Moya-Moya sometimes. These were two unrelated boys, 17 and 14, that know each other, and I treated. And I like to show this because usually people tower over me. So and these kids are very social and often very bright and amazingly well adjusted in society. So in pediatrics, much as the Asian literature has suggested, our series is similar. More than half the patients present with TIAs or stroke. Those are lack of blood flow symptoms, and only 16% with hemorrhage. Interestingly, about half have headaches, and a quarter percent with seizures. These are overlapping symptoms. In adults, as opposed to the Asian experience where hemorrhage is the primary presentation, our series shows that it's still primarily lack of blood flow, TIA and stroke in the vast majority, and only 16% hemorrhage. Again, headaches are a common presentation. I don't know how many of you have had headaches, but we find after revascularization, often the headaches improve significantly or resolve. As I mentioned, I think this is an underdiagnosed condition. We had 11 patients that were misdiagnosed with multiple sclerosis from 2 months to 19 years, and they were not treated appropriately until the correct diagnosis of Moya-Moya was made. Sometimes they had multiple strokes, and it was thought nothing could be done. We do an extensive evaluation preoperatively. Those of you at Stanford who have been treated at Stanford know that. Lots of blood flow studies. We're not sure what the best test is for blood flow, but we're doing neuropsych testing. And the ultimate idea is to see if revascularization improves the cognitive function after in Moya-Moya. This study we published in 36 adult patients before surgery now showed that a third had cognitive impairment. It was very severe in some. And interestingly, the problem was in executive functioning, not in memory or intellect, which were spared. We just submitted this paper. And these are adult patients before surgery who had no MR evidence of stroke. So they hadn't had any strokes, and despite that, 23% already had significant impairment, again, in executive functioning, high anxiety, depression in the third. And the patients who had higher baseline cerebral blood flows actually had better cognitive function. So this brings up the issue of whether earlier surgical intervention with revascularization can actually prevent cognitive impairment even before you have stroke. So we hope that's true. We don't know that for sure. We're using some new methods of looking at blood flow. This is a special technique where you can look at the large vessels and you can look at the flows, and we want to see if that has predictability. This is how I do the procedure. Usually take the artery in the scalp, that's right in front of your ear, and use this parietal branch, which goes straight up unless it's small and the frontal one is larger. And then we isolate the artery with a cuff of vascularized soft tissue around it. Then strip the muscle from the bone over the temporal region, put in a hole, a small